My name is Natalie Sullivan. I am an emergency medicine physician in Washington, D.C., and a fellow in disaster and operational medicine at George Washington University. Today, I'd like to talk to you about the clinical implications of ransomware, something that I personally experienced while working in one of our local hospitals. Just to begin, I think a lot of times in the news, when we talk about ransomware attacks on hospital systems, a lot of the focus revolves around patient information exposure. While I completely agree that the exposure of personal and medical information can have grave consequences to the individual, what I'm really focusing on today are more of the direct clinical impacts on morbidity and mortality. To start, I'd like to introduce you to Mrs. Jones. Mrs. Jones is an average patient we may see any day in our emergency department. She's a 71-year-old woman with a history of high blood pressure who was working in her garden earlier today when she started having chest pain. When Mrs. Jones first arrives at the emergency department, she's going to encounter two people. One is a registration person who will enter in her demographic and personal information so that it is part of our computer system and so that she can be billed at a later time. She'll also be met by a triage nurse who will collect some vital signs, do a brief interview about her chest pain, and place in the computer a small note, her information, as well as a sense of the severity of her illness. As soon as she enters that into the computer, it will be available on an electronic board that any staff member in the emergency department can access. Next, she is going to go into the waiting room. So while she's in the waiting room, sometimes nurses will be able to order what we call some protocol orders, such as a basic EKG or some lab work. But otherwise, she's going to be waiting there anywhere from a few minutes to several hours, depending on occupancy in the emergency department and our capacities to see more patients, as well as her initial severity score. When a bed opens up and we bring her back, she's going to be evaluated by a physician or an advanced practitioner who will conduct a history and physical exam. Then they will go back to the electronic medical record and see if there's any information available about her past medical history. This could include things like whether or not she's ever seen a cardiologist, whether she's had a cardiac catheterization, or any other background information that may not be readily apparent to the patient as important, but that we are certainly going to use in our analysis of today's visit. Based on our evaluation, she will go on to have blood work, perhaps an EKG, perhaps some radiology to further evaluate her chest pain. When those test results are available, she will be again reevaluated by the provider. They'll discuss the results of her testing and make recommendations for whether or not Mrs. Jones should stay in the hospital for observation, whether she may need a procedure, whether it's safe to send her home, or perhaps if she needs to be transferred to another hospital for further evaluation. At each step along this pathway, we are going to utilize technology to help Mrs. Jones. Technology in medicine has significantly advanced the standard of care that we have provided and has not only facilitated a more thorough evaluation, but also more efficient evaluation. So starting from the beginning when she's registered and all of her information is instantaneously available on the electronic board, that means that everyone in the emergency department is on the same page regarding where she is at in her care. We all know what her vital signs are, we know what her complaint is, and we will be able to track over time where she is in this process. As I mentioned before, the electronic medical record is not only a place for us to record information, but it's also allowing us to look back on all of her past visits and to provide information to her current and future providers through the chart. It's also the place where we order labs, order radiology, and order medications, and has several built-in checks and balances to prevent medical errors. When we order labs electronically, they instantaneously go to the laboratory. The lab uses electronic machines to conduct the tests, and then as the results are available, they're instantaneously sent back to us. We utilize multiple medical devices in order to monitor Mrs. Jones, but also to administer medications and treatment. Often she'll receive medication using an IV pump that is electronic. She'll also likely be on a cardiac monitor that is going to alarm if she has any abnormal vital signs. All of this allow for us to administer care to her in a safe way, even when we're not in the room. Similar to the lab, when we order radiology, such as Mrs. Jones' chest x-ray, that order is instantaneously going to go through the computer to radiology. A machine is going to take her x-ray, and then any radiologist who has computer access, as well as the ER providers, are going to be able to instantaneously read that imaging. So let's go back to Mrs. Jones and think about what her experience would be like on an abnormal day, a day where the hospital has been attacked by ransomware. As we think about this and go through the different systems that have facilitated Mrs. Jones' care, I want you to think about this concept of various vulnerabilities with variable consequences. All along this pathway, because of the lack of technology, we now have multiple opportunities for error and for delay, and the consequences of those seemingly small vulnerabilities can range anywhere from minor to catastrophic. So when Mrs. Jones comes in this time to triage, the same information is taken down, but rather than being instantaneously available on our electronic board, it is now on a paper chart. And so that information, while obtainable, is only seen by whoever is physically holding her paper chart at any given time. We're not able to monitor who is in the waiting room with what vital signs in real time, and it is an opportunity for things to be missed. Once the provider is able to see the patient, which is often delayed due to the inefficiencies of time and increasing number of patients in the waiting room, there are many additional steps for them to complete their evaluation. Not only do they now have no access to the patient's past medical history beyond what the patient is able to offer, but they also have, instead of 5 steps, now about 10, 15 steps in order to complete all the orders that they want. They need to physically carry charts to the people that are responsible for carrying out orders, and they also have to have a new method of retrieving them. For labs and radiology, there's no longer instantaneous information transfer between our department and these locations in the hospital that are completely separate. So either a person who would normally be completing their clinical duties needs to physically go back and forth, carrying orders in and results out, or you rely on more antiquated systems such as fax machines that traditionally have not worked well for us in these situations. In terms of treatment, we have the added complication of not having a medical record to check our orders. So when you would normally have an alarm telling you that the patient has an allergy to a medication or that your dose seems odd, you're now completely dependent on your first try writing down an order. There are also multiple machines that allow us to dispense medication that can be impacted by these systems failures. Another important thing to note is we're talking about one patient's trajectory through one emergency department visit, but this is happening to every patient in the emergency department and is impacting our whole hospital, which is then impacting the whole hospital system of the city. If there's one major trauma center that cannot take care of trauma patients in a timely fashion, that's going to dramatically impact how patients are taken to other hospitals as well. I want to draw attention to the fact that what used to be a streamlined 3 or 4-step process is now a 20-step process that not only involves new administrative steps, but is actually involving physical steps as clinical staff have to physically move around the hospital in a way that they didn't previously. Each one of these steps opens up our opportunity for medical error. In medicine, and particularly in emergency medicine, throughput is a measure of quality of care. So hospitals track things like time to provider, time to disposition in order to give an indication of the quality of care our hospital is providing. Even more importantly, there are certain critical diagnoses that have been proven to have increased adverse outcomes outside of very specific time windows. So for example, if Mrs. Jones is having a heart attack, she has 90 minutes from the time she reaches the door of our emergency department to the time of cardiac catheterization before she's at risk of severe morbidity and mortality. There are very real patient costs to each of these delays, and though they may seem minor when taken individually, they add up and may be the difference between someone's life and death, and most certainly is the difference between low morbidity and high morbidity. Before the adoption of advanced technology, the flow of patient care was more simple and at any given time consisted mainly of a triangular relationship between the provider, the patient, and a third party. Mrs. Jones' medical care is now a web of interconnection between all of her providers today, those in the past, and in the future. However, when struck by a ransomware attack, it can feel as though we're practicing in a fog, especially for those without the institutional memory of paper charting, such as myself. It's a very confusing time if you don't have proper preparation. So how do we as clinicians clear that fog? We can start with our own cyber hygiene, making sure we're paying attention when we receive hospital training regarding phishing attacks and safe password use. We should be active participants in cybersecurity exercises and be familiar with our downtime procedures. When you're experiencing a cyber attack, should not be the first time that you write your first paper prescription or use a paper chart. By familiarizing ourselves with our role during downtime and the correct patient flow, we can learn to optimize and mitigate risk. To conclude, I hope you'll take home these points. Modern hospital systems rely greatly on technology to deliver an advanced standard of care. Ransomware compromises patient safety beyond the exposure of patient information, and the clinical staff can have an active role in preventing and mitigating morbidity and mortality associated with future cyber attacks. Thank you for your time, and I look forward to answering your questions.